Thank you very much, and good afternoon, everyone. Thank you for allowing me to share the experience from Thailand with all of you here today. I'm going to introduce you briefly to the HIV epidemic and also the national AIDS strategies in Thailand before I will go to explain to you a bit about the test and treat study among MSM and transgender women in Thailand. I have no conflict of interest to declare. And over the past decades, we can see here that MSM and transgender population actually contributes to the largest and increasing proportions of new HIV cases in Thailand. And it's not only until this year that the data collected from transgender women was lumped together with men who have sex with men. And Thailand currently have approximately 8,000 people, 8,000 new HIV cases each year, and we aim to end the AIDS epidemic by the year 2030 based on the test and treat strategy. And the testing will need to cover 90% of the key populations, and the treatment will be offered to everyone regardless of CD4 count. And we base the national strategies on the recruit, test, treat, and retain cascade. And what you can see here is that over the past few years, we have not been doing that good in terms of getting people to test early and also to link people into early treatment and also to retain both HIV positive people in care and also HIV negative people into retesting. So we have now, over the past few years, have put more intention to increase the importance of community-based involvement into the model. Since what we have learned here is the pictures or the data figures from when we use the conventional way of recruiting people into testing and also use conventional way of provide the testing and the treatment service in facility-based setting. So in year 2012, that was the time that the Thai Red Cross AIDS Research Center has started the collaboration with the Department of Disease Control at the Ministry of Public Health to implement the test and treat study among Thai MSM and transgender women. And among around 800 people we enrolled in 4 provinces at that time, we have found quite a high acceptance rate for immediate ART initiation. But at the same time, we also found very high incidence rate of HIV among these MSM and TG in study sites where high quality HIV counseling, risk reduction counseling, HIV testing, STI services are already provided. And at the same time, we also found very high rate of STI among this population, especially among HIV positive MSM, who will see 2 or 3 times higher prevalence of gonorrhea, chlamydia, and syphilis. And we also found a correlation between the presence of STI in certain body compartments with the presence of HIV RNA in that compartment. So when you have anal chlamydia, that means that you also have high chance of the detectable HIV RNA in the anus as well. So all of these together has partially supported the movement of the Thai national guidelines in 2014 to recommend ART for everyone regardless of CD4 count, and also for the first time for the national guidelines to have the HIV prevention chapter, which recommends post-exposure prophylaxis and also PrEP and STI management as part of the combination HIV prevention package. And this is the preliminary data from the 12-month prelim data from our Thai MSM TG test and treat study. And what you can see here is that we, among those who tested positive at baseline, we were able to link 90% of them into care, and 85% started ART, with right now 74% reached that viral load suppression that is less than 50 copies per mil. But please note that this is 99% out of 104 people who already had viral load at month 12. So if you look at 99% out of 104, that's 95% of these people who had undetectable viral load. And at the same time, when you look at HIV prevention cascade, so among those who tested negative at the beginning, we were able to have them come back at least at 12 months to have retesting. 94% of them came back for HIV retesting, and 92% remain HIV negative. When we look at baseline CD4 count among those who diagnosed at baseline, we are not doing very good. As you can see here, that around half of them already had CD4 count less than 350. But at this median CD4 count of around 350, that's much better than the national data. And at month 6 and month 12, more than half of them already had CD4 count above 500. And if you look at the viral load, let's look at viral load less than 1,500 copy. If we consider that as a transmission threshold, 96% had viral load less than 1,500 at month 6, and that number was 99% at month 12. So in 2014, the country has now moved to expand the test and treat study to now include another 7 provinces in Thailand, and also to compare 2 models. One is the community-based model, which will recruit participants from drop-in centers and provide testing and plus minus treatment at the drop-in centers. And these are drop-in centers who are working with MSM, male sex workers, transgenders, and transgender sex workers. And another component will recruit participants from the facility-based setting, which is the main hospitals in 5 provinces. And we will also do the costing study in this expanded phase as well. And also PrEP will be integrated into these 2 models as well with the study for cost effectiveness. Because although I mentioned that the PrEP was now recommended in the national guidelines, but it was not, has not been covered by any national healthcare insurance scheme. So people will have to pay if it is outside of the study. So this, there will be 6,000 people enrolled from the community-based model, and another 2,000 people enrolled from the facility-based model, and 300 each of HIV negative participants will be enrolled into the PrEP substudy. And we started enrollment in May this year, and each participant will be followed up for 18 months. And just to tell the story a bit about how we have built and strengthened capacity of our community-based partner, because from what I've heard this morning, Thailand is much behind Africa in terms of implementing the community-based services, and also moved from community-based into community-led service, and now to do community-based research. And what we have done is that we provide both the clinical and laboratory skills with collaborative efforts from all stakeholders involved in the country to build the capacity and strengthen the capacity of the drop-in center staff to be able to provide HIV counseling, provide finger prick blood collection, which is still not legal in Thailand. So this is done, we consider it under research study. And also to have them perform HIV testing, syphilis testing, and also point of care CD4 count within the drop-in centers. Also, they have to have this STI sampling collection skills as well, so to collect samples from vagina, anus, oropharynx, and also most importantly the care and support skills to be able to link people diagnosed within the drop-in centers into care, and so retain both HIV positive and negative people into the program. And so within the past year, that we feel that our community-based partners are fully skilled to provide community-led service. Now they are moving towards community-based study. So they have been involved in the full research cycle. So from the designing of the research questions into developing the protocols, developing data collection tools, plan their own study flows in the drop-in center, and also to plan community forum and also ongoing communications with their own community. So they have been trained also for GCP trainings, and we use the site initiation meeting, coaching, QA/QI, all these visits to provide continuous support. This is to ensure that they are still doing what they are doing best, which is providing service to their clients, while also these efforts should be well balanced with the high quality research that is being done at these drop-in centers. So in conclusion, we now, Thailand, I think that we realize that both the facility-based and community-based service delivery models are needed to achieve national goals. And the real challenge is that how we are going to get to use these models in a scale that is large enough to allow more people to know their HIV status and be linked to care. And clearly we have learned that the collaborative efforts among various stakeholders are really needed, and community involvement is increasingly essential in order to aim at ending AIDS epidemic in the next 15 years in our country.